Hi, everyone. I can see people popping on, so I'll just wait a minute till we have more of you on, and then we'll get started. So I'm just going to give it a few more seconds. All right, so I'm going to get started. I'm Sherry Carlson. I'm Senior Director of Programs for Let's Grow Kids. And we have with us today Breena Holmes. She's not only a pediatrician, but she's the Director of Maternal Child Health for the Vermont Department of Health. And she's going to lead our presentation today. Some of you sent in questions, and those will be addressed at the either incorporated throughout the presentation or at the end we'll address those questions. You also can use the Q&A to put additional questions as we go along, and we will get to as many of those as we can. There's a lot of you signing on today, so we might not get to all of them. And what you can do is following this presentation, you will get a survey, and there's a space for you to add a question or to send any other notes that you'd like us to take a look at. And those really are looked at, and they're incorporated and studied in terms of when they're updating guidance or what other information needs to get out to childcare programs and early childhood folks. So it's really worth taking time to do that. And with that, I am going to turn it over to Breena Holmes. I also want to mention that we are recording this webinar, and we will post it next week on our Let's Grow Kids website. So if you have colleagues that didn't get a chance to attend, or it will be there, or if you want to go back and listen to some pieces again, it will be posted next week for you to be able to do that. So I'll turn it over to Breena.
Hi, everyone. Thank you so much for taking time with us again today. I do have a few slides at the onset here to just get us sort of grounded on August 6th. It seems like years and years that we've been working together on this, in this important space, but it's really been just, depending on how you count, 5 months. And then I do have some of your questions from before that came in, and I will address those, and as Sherry said, do our very best to answer others as well. So I need to just start with deep gratitude for all of you. And I can't even tell you how much I've learned from you, how much our team has really appreciated the thoughtful, intentional questions and dialogue that has gone on really since March. We mark at our calendar March 9th as a day in public health when we started to really know that we needed to drop all of our regular work and focus entirely on the impact of this virus on Vermont's children and families. And you know, Holly Morehouse often talks about this, what is the story we're going to tell when this is over, about how we worked as individuals and together. And I just really want to acknowledge that your field and the way you've all approached this has been incredible, like truly incredible. So thank you, thank you. I put this in every talk, and it's true. The COVID situation continues to evolve rapidly, and information we provide today may change. We are scientists in public health, and we read every study every day, and our job is to interpret it with the right scientific thinkers and bring forth our best advice and thinking about how to be in Vermont. And we have a very different situation in Vermont than any other state in this country. So today I decided to throw up a very complicated slide with apology, but this is a health department way of tracking what we're doing since, I guess there you see it's actually March 2nd. This slide has three things going on. There are gray and maroon bars where all the negative tests that were done. And those are, the reason they're different colors is we have different places that tests go, different laboratories. That green sort of olivey color is the percent of the tests that we did that came back positive. And the percent positive has become the most important indicator to determine the prevalence of this disease or this virus in our state. And we have not been above 2% since April, and we haven't been above 1% in over a month. That is extraordinary in a public health data system. Most states are grappling right now with positivity rates in the 10 or 15%. And many, many states have set a bar for opening schools at 5% positive. We're at 1% positive, despite the fact that we do an enormous amount of tests per capita in this state because of incredible efforts on the part of University of Vermont and the health department. So that's also part of this graphic to show you how we've gone up in the number of tests that we perform every day. And then, we have some variation, but we're somewhere in the thousands, sometimes 1,500 tests a day. So really quickly today, we're going to just look at childcare guidance to dig into some of the ongoing nuance and some of the new stuff we included in July. I do want you as great partners to hear from me about safe and healthy school reopening guidance, and then it's mostly about questions and answers. We revised our childcare guidance for the 4th time on July 13th. I know you all know that, but because now it's over a month or just a month. What we noticed is we continue to have a lot of questions from you, and we really have to get better at explaining illness and what parents should expect in terms of exclusion from care, because no one sick is going to childcare, summer camps, or school. It's a major culture shift. It's super hard on you all because you're forced to say to a family, I can't have this child in this care today, in this environment. And I know it's really hard, and you need much more clarity from us on how to get kids back. So someone leaves sick or someone doesn't come, how do they come back? Do they come back the next day? And what is how do you assess that as a non-medical person? So we are currently working on algorithms to make it super, super clear which kids are so sick we really think they need to see their doctor and probably get a test for COVID, which kids are having mild symptoms not really associated with COVID that would just recover and then return. I did want to note that back in July, we changed the return for fever criteria to 24 hours. It was 72 hours, March, April, May, and June, because early on, we had to make assumptions that most kids had to stay out in case they had COVID, because we didn't know what we were dealing with. We didn't know what was going to happen, and we didn't want COVID in your buildings or your homes. Then, with less and less and less cases and very little virus in Vermont, we were able to fall back on general infectious disease principles that when fever resolves, you can return to care or school. So a few other really important points that we've learned, and this is really another shout out to you all and all the work we did that was hard but important together in March and April and May. So when we set forth to write safe and healthy school guidance, we were instructed by our leadership at the Agency of Education and the Health Department that it was guidance that school districts would take into their hands and implement with their own approach to various aspects of implementation. And that's what how schools function in general, that there's general guidance, and then they have a lot of decision making at the local supervisory union or district. However, once the guidance was released in June, many school districts fed back to us that they felt they needed the guidance to be more standardized and that they wanted a general approach to the whole state, which led to some of the kind of press and some of the confusion about why one district's doing one thing and one's doing another. So that's been taken back through the leadership, and the decision remains that guidance is guidance, and school districts are going to be using their own autonomy to make decisions. I think that's really important. We all know that, because it's being perceived or expressed in the press a little bit like the state didn't want to do statewide guidance, and that's not true. The other thing that is so much the way you all functioned is there's a lot of planning that you can do if you have time, where you think and think and think about what you're going to do. But in quality improvement, there's this important concept called Plan, Do, Study, Act. Many of you know it. It's the cycle in which you plan, then you do it, then you figure out what's not working or is working, and then you make changes, which is exactly what childcare and summer programming has done. So you didn't have the luxury of any planning, especially those of you that did emergency care during essential workers, for essential workers. So we're now in weeks and weeks of planning at the school level, and it is time to start. And I just, those of you that have overlap with your school districts or have relationships with local folks, I just know this in my heart, that until you start, it's hard to know what's right and what's hard and what needs more clarity. And then the final concept on this slide is the way we've been successful in Vermont, and we have been so successful. I do not want to forget to remind us all of that the national news is heartbreaking and it's hard to watch, but we are experiencing an extremely low prevalence of this virus in Vermont, and it's the right time to open schools. But the way we're going to maintain that safety is with communities staying safe. And that means everyone has to follow public health guidance, not just people who are parenting or working with children. And I know you're all citizens of the state in a way that you know what I'm talking about here. This is a community-wide decision to protect each other. So our website has all the guidance. I did want you to know, if you're in leadership roles in your community and you want to speak to groups, that the school guidance does have a PowerPoint associated with it. We have revisions coming out tomorrow of the safe and healthy school guidance. So you've also followed the story, both state and national and internationally, about children in COVID. And what I wanted you to know in Vermont is that, probably different than other states, our pediatric infectious disease doctors, our pediatricians, and our public health people, including scientists, meet and talk every day. And it's a function of our size, but it's also a function of our long-standing commitment to integrating public health and clinical medicine, and I'm really grateful. So the groups have come out together with these 4 statements. In Vermont, children are less likely to become infected with this virus. Children are less likely to develop severe disease, and particularly younger children under 10 are less likely to transmit this virus. And in countries that have low prevalence, like Vermont is experiencing, schools have been opened successfully without outbreaks. So we are much better off comparing ourselves to Europe than we are to other states in this country. Very quickly, this is the group of stakeholders that is continuing to advise the guidance, because we intend to revise it as science continues to evolve. We were also able to share drafts with young people and youth, teachers, and parents. These were the overarching goals, but I did want to just draw our attention to the first 3, because this is all of our brains work a little bit differently in how we process information, but these first 3 bullets are very helpful in the way you've interpreted the guidance and set up your childcare environment. You have to decrease the risk of the virus ever even coming into the building, and you do that with sick people staying home, and you do that with health screens. including the temperature checks, which we're continuing to recommend. I know they're a lot of work, but they're important. The second way that we need to work together is to stop the transmission once you're in the building, in case the virus sneaks in through those other mechanisms. So if, you know, sick people should stay home, we know that doesn't always happen. Once you're in the building, the transmission is decreased with masks. And we'll talk a little bit more about masks in a subsequent slide, but we stand by the guidance, and so does the governor, that childcare is strongly recommended. We strongly recommend in childcare that children wear masks and cloth coverings. His mandate is for everyone over 2, and we know there's those don't line up, but he knows about our guidance, the governor, and agrees that that stands. But we still want you to try really hard, and we still want you to understand why it matters. And then if kids can't tolerate masks, then you're not going against his mandate. And then the other way you keep the transmission down, if it happens to come into your building, is with all that cleaning that you're doing and working in different ways to keep people apart, some distance. And there's some growing science that 3 feet for kids under 10, if they're masked, is safe. So again, nuanced, because if they're not masked, you should still work harder on the 6 feet. And then the last piece of the first 3 bullets is we have to figure out who has COVID and get them identified, and people that are identified as close contacts need to be quarantined. So that is the part the health department is most confident about. We have great testing capacity, and we also have an incredible group of contact tracers who are quickly figuring it out, so you know what to do. I do not need to talk to you all about the importance of childcare in schools, and that's the guidance. So again, a little bit more about cloth coverings. We knew, obviously, as the same group of people, that the childcare and summer guidance said strongly recommend masks in children. The school team was not willing to use the word recommend, and it is required that all students wear masks in public education. I was able to get a sentence in at the very last minute in the guidance for schools that says special considerations for pre-K, because I knew it would be very confusing to the field and to our parents that there were different rules for 3- and 4-year-olds in public school or communities. And I really want to hear from you about this, because I'm acknowledging it's hard that it's different. This is just a quick slide on group size to show you that there's this very epidemiologically driven frame in our school guidance that describes where you are with your data. Vermont has been in what's called step 3 since May, and that means you can get more people together, as you've watched the governor do, and you can also just try to space people out to the best of your ability without a lot of measurement of 6 feet. The schools wanted to start in step 2, and that's because they hadn't had any practice with this setup. They needed time to figure out their workforce and their staffing, and they wanted to be ready in case they needed to step back if we had more cases or the virus returned to Vermont with more volume. So I know that's very nuanced, but that's what's happening. And that is why you're hearing a lot about the sort of setup of schools being a little more restrictive. I just wanted to remind you of Help Me Grow. I know you all are aware of it as a resource for families and for you all as early childhood professionals. We do have a mega uptick in the use of the call center, which was great because it showed that in times of crisis, we had a resource connector. We also were able to step up the Help Me Grow referral center for the pediatricians who were not seeing kids in person, but still wanted to do developmental screening. And we now have a much more robust developmental screening online system through Help Me Grow 211. We have an incredible website. I know you've all been on it, but I'd like you to continue to check it because it gets updated a lot for schools and childcare, and it has a frequently asked questions section that's really helpful. And then we have tons of other resources if you're wanting handouts for parents, both about the experience of just being a family during COVID, but also we have very specific handouts about what to expect for childcare, multi-system inflammatory syndrome, and also kind of a checklist for you all about your daily or weekly activity in COVID. Very authentically, if you have a resource that you wish, if there was a resource you wish you had that you'd like the health department to develop, please let me know. We're interested in getting the right materials to you and your families. Okay, so here are the questions that have come in so far. Sherry, am I doing okay for audio, and is it okay to keep going on questions?
Yes, you're doing perfect. No glitches so far.
Jeez, what a good day. We'll tell the group later about our earlier in the week. We have not had our best technology week.
We have not.
Okay, I think I started to address this a bit. So here's the situation. And I'm sure you've grappled with this. The American Academy of Pediatrics national team came out several weeks ago and said there's some evidence that 3 feet is safe for children. And we took that into consideration when we first produced school guidance back on June 17th. We had language in the guidance that's made it, we thought as a task force, made it sound like 6 feet's the gold standard, but do the best you can. But the schools took it as a hard stop, said it says 6 feet, and therefore we can't open with all the kids. And that's the lessons with COVID. That's that Plan, Do, Study, Act I described earlier. So we went back to the scientists. We've asked our infectious disease doctors to read every study about distancing of children with masks, and they have come up with a strong recommendation that if you're pre-K through 5th grade, that you could be 3 feet apart safely with masks. So that is being taken into consideration in the updating of the guidance for tomorrow. And then the rest time is, we're pretty clear about that in both guidance, which is you go head to foot when you're not masked. So I think I answered that. If you really need to still work towards 6 feet if you're unmasked. School teachers are supposed to stay in a teaching bubble. What about pre-K teachers? Our kids cannot stay in desks all day, nor should they. Fewer kids, is anybody operating at full capacity? Okay, so I can't really speak to exactly how schools are rolling out the pod situation or the way school teachers are being assigned to classrooms and students, because that's all playing out real time. But what I will tell you is, you have all shown us for weeks and weeks that there are parts of this, the mitigation strategies in public health that work with kids and parts that don't. And all of that is still leading to very minimal transmission of the virus and almost no cases in childcare and summer camp. So what I would say to you all is, first of all, you're doing extraordinary. Like whatever you're doing with masking and trying to move about with a little bit of distance and cleaning is working. So the pre-K question is really, what can pre-K learn from all that the others of you have been doing with kids since March, and some of you since June? I just know that it's working. So we're not as strict anymore. In the very, very beginning, we were keeping every pod separate because we just didn't know what was going to happen. But we've had so much success that we're starting to say an after school pod, if there's a group of kids together during the day, they can then mix in the afternoon with a, still with an eye toward 25 as a kind of best practice number. That doesn't mean that groups aren't getting together that are bigger. and our governor's allowing 150 people with enough space to be outside together. So it's just a notion that if there were to be a case, it's a lot of contact tracing if you have big groups that are close together. So this is a nuanced answer, but I did want you to know we've watched you do it, knowing the kids are not 6 feet apart at times or very often, that most of you are successful in working with children to wear masks, but there are kids who can't, and we're still at the lowest prevalence of this virus in the country. Please put to rest the question about little kids not spreading the virus. Are they really more asymptomatic? Okay, these are two separate questions, very importantly. There are so many studies, so many, like over 100 from around the world that show less spread in kids under 10. But there was one study that just came out that was in JAMA Pediatrics that made it to the national news that showed kids had virus in their nose at very high rates. But it said nothing about the transmission. There is no transmission analyzed in that study. So there's something going on here, but it's not transmission. And that's what matters for the way we talk about this. So being asymptomatic, as those kids were in the JAMA Pediatrics study, and having virus in your nose is important to observe and wonder about. But the current scientists' clear statement is those kids don't spread the virus. So with any great detail, to account for any spread or outbreak. It doesn't mean there wouldn't be one case somewhere where kids spread it. But in our experience in Vermont, where we've had one major outbreak involving children, it's Winooski. Every kid that tested positive for COVID got it from a household contact, adult. So that's our experience to date in Vermont. What is working in centers now open? We need more detail on cleaning toys and systems that are working. I could not agree more. Sherry and Let's Grow Kids had a great taped webinar, it's probably weeks ago now, where they brought forth amazing childcare folks who had been working through emergency essential worker, talking about exactly this. So I'm not the expert in this, I just know it's working. And the routines around cleaning definitely need, you need to hear from the field that, because people have figured this out in a really powerful way. Okay, apologies for the lots of text here, but I'm taking it exactly from you so I don't, risk paraphrasing. It seems that at least some of the outcomes cited were based largely on the time at which adults and children tested positive for COVID. I keep thinking to myself that it seems possible or even likely that some of the children may have had the virus but were asymptomatic, then they transmitted to their parents who exhibited symptoms and then got tested and found to be positive. This is very high level critical thinking. This person is a scientific thinker. So I see the logic here and I follow it. In Winooski, however, where we have the most experience with this, the adults were tested whether they had symptoms or not because they were known to be in contact with another adult with COVID. So it all transmitted down through known cases in adults. So, but this hypothesis here, or this wonder, is important. It's just not been our experience in the way it rolls. And when you do universal testing around the world, other countries, they aren't finding that the kid ends up being the source with their research in general. So I do know that, I'm here very sincerely to talk with you about what we know and don't know. And I continue to feel the energy that there's too much unknown. But we also have figured out safe mechanisms to keep you and kids safe since March, when there was way more virus in the state. The second question that's also hard, I just can't shake the feeling that just because the adults were tested before the children doesn't necessarily mean that, oh, wait, is that the same? No, I think it's the same. I just put a second bullet. I'm concerned about the possibility of children in the classroom being asymptomatic, but who still spread the virus to their peers and adults, many of whom are higher risk. What is your opinion about the extent to which transmission seems to occur from adult to child, but not the other way around? Yeah, so it's not really an opinion, it's my belief in our pediatric infectious disease doctors who have told me that it's safe to open schools and that if adults are masked, they're going to be safe in classrooms. And that children being masked is an extra bonus to the risk to get it to not zero, but as low as we can in a state with low prevalence. Okay, again, apologies for small font. What is the guidance around parents coming into the program with their child, particularly for the first few days when children are entering a strange program? They don't know who are wearing masks. So we actually address this in the guidance to say parents cannot visit at will, you know, anytime, any place, but we completely acknowledge child development transition, and with a health screen and a mask, parents can help their children transition. And if anything I say is not popping in the guidance, I'll find it for you and get it out, because it's too many pages long, and I completely get that sometimes it's one sentence buried in 24 pages. So part of the reason that we have our public health nurses really available to you all is so we can pull up the guidance together and see where it is. And so please call directly as well. Several kids came down with symptoms, saw doctors, got COVID tested, all that done, and having negative results. How do we approach the child still having a consistent light cough, runny nose from what was a cold? If it lingers on past a week, at what point symptoms do we exclude? Or does it completely revert back to the health regs we normally follow? At what point does the previous COVID test become invalid? Again, this is such a high-level, critical thinking, awesome question that's almost not answerable because there's so much nuance. When the child gets tested matters in this story. So if a child is tested 7 days or more into symptoms and is negative, I feel really good that that's not COVID. But if you get tested too early, before 7 days, and then you're negative and you come back and you persist with symptoms, that needs a medical evaluation. But more importantly, that kid shouldn't really be in your care. And I know this is probably exactly what you experience every day. So the kid has a negative test, which is great. You may or may not know what day of his symptoms he was tested, and you're being asked to take him back with respiratory symptoms. In the pure interpretation, including mine, of our guidance, the symptomatic child should still stay home even with a negative test. I also like that this question referenced when do you revert to normal guidance, back to the licensing division. So what we talk a lot with our school nurses about this too is we have to remember all of our general infectious disease principles as well as superimpose this pandemic. So I just think we got to a place pre-COVID where we let too many sick kids and adults wander around our society. You've heard me say that. So I don't think the test would become invalid, but persistent symptoms with a negative test is very unlikely to be COVID, but it's still some sort of viral infection that shouldn't be in a child-serving setting for just general infectious disease principles. Ooh, sorry, I really want you to know we're meeting 3 more times. We've met 3 times this week with pediatricians and school nurses to create algorithms. Who should get tested, who should go to the doctor, and who can come back and when. So it's coming, it's just not helping you real time. And I know you've been at this for months. So leaving it really clean that people with symptoms stay home is safest. Many providers are using aerosol Lysol spray on toys. Is that effective? Yes, that is fine. It is a supply chain that is not infinite. We've heard a lot about running out of Lysol sprays. So also for our public health nurses, any question you have about environmental health or cleaning, please send to us, because we have an environmental health expert that actually will analyze products for you, because each product has its own safety protocol. A child stayed home from our program earlier in the week with a runny nose and returned today. Does the health screening, during the health screening, the child showed no signs of illness or runny nose. We remained outside the entire time the child was at the program. And while we were outside, the child developed a runny nose. Is a runny nose a reason to call a parent to come pick up the child for the program? Okay, there's something implicit in this question, which is, if the child didn't have a runny nose at the beginning or indoors, and there's something about outdoors that elicited the runny nose, that sounds like an allergy to clinical me, person with that background, if there was no fever and the kid was well otherwise. So I think this requires you to know your kid well. If this child did not have known allergies, this would be considered a new symptom. And yes, the parent should pick him up, figure out if it's new allergies, and welcome to return, not with a note, just with an acknowledgement from parents that it was just diagnosed by a clinical person as an allergy. We've gotten, my pediatric colleagues want me to continue to reinforce with you all, the guidance does not require notes for return. This is about relationships, and you all encouraging and knowing parents are going to seek guidance about asthma and allergy, and also persistent other symptoms. But trying to get medical notes and medical clearance is not our pathway in Vermont. It's too much administrative burden, and it's too many kids. Can essential oil diffusers be used safely during inside time, or is the goal to reach a recommended humidity level with the use of a dehumidifier? And what about the use of air filters? Could this be part of the plan to protect ourselves? So the first, essential oil diffusers are not a good idea, because they're not moving air away from people. They're using existing air. And that's the same answer for dehumidifiers. There is, the air filter question is the one I would need help with, because I don't want to imply or make you think you need to go get something. We just need air to circulate well in classrooms. And I don't know your general, if this is a question that's associated with a school building program. I will tell you that your school teams are all have environmental health teams right now, and they're working very hard on each individual classroom's filtration and air movement. But anything like a fan, a dehumidifier, or an oil diffuser that takes existing air and just moves it, we're not recommending. We are recommending fans, box fans, that go in windows and move air, come in with air, and then another box fan that moves air out, if you happen to have two windows. And this is also, I would draw your attention tomorrow to the school guidance, because it's got deeper and longer in the environmental health section about the air for tomorrow. Okay, that's the part, those were the questions I had ahead of time. I'm gonna stop and let Sherry take over with what's come in since.
Thanks, Breena. So I just want to acknowledge that there were several questions about the runny nose thing, which I think you covered several times, but I just want to acknowledge that those came in. There was a question about, will vomiting and nausea be added to the COVID healthcare guidance for childcare?
Yes. So I'm not sure if this, how this space feels to you all, and I really want to acknowledge that every time we take something off and then add something back, it's incredibly disruptive, and you're just being you're tossed in this storm with us. The infectious disease doctors wanted nausea and vomiting off the list because it's low prevalence in children, and they felt it was such a common symptom, it was going to exclude and create just complete infectious disease bedlam. And then it was noted to us by many, many people that having different lists for adults, different lists for schools, and different lists for childcare was not sustainable from any perspective. We brought it back to infectious disease guys, and they said, oh, all right, put it back on. So it's less than 1% of any of these kids have COVID. And all of these symptoms are so common in pediatrics, it's palpable to me. But it's a pandemic, and we're just going to live with long, comprehensive symptom lists to keep sick people home. And the silver lining on this one is that it's going to keep us healthier from things non-COVID through a fall and winter where we're really going to need discretion. And it's my only observation is, I hope you share it, that, you know, people joke, my kids are teachers, and people joke like, oh, wait till you see how sick you get as a teacher, because kids come in, they're so sick. I'm thinking, like, that is not the right messaging for anyone. And pediatricians too, we were always counseled we were going to be very sick, you know, of course we were, because we're doctors, people bring sick kids to us, but teachers shouldn't have sick kids in their face all day. But obviously you've heard me talk, I know we don't have the right social policies in this country to support working parents to have sick kids, so it's a complex problem. But in COVID, sick people stay home.
There's a few questions about the health screening. One is if a child has a temperature of 100, what to do? And the other one is, what are the questions that should be asked during the health screening, or are there questions?
Oh, great questions. 100.4 is a fever, 100 is not. And I know that's ridiculous, but it's been cleared by all the infectious disease folks, and you have to pick a number. And it's based on great research. So 100 business as usual, 100.4 excluded. Yeah, the symptom list is in the guidance. I can pull it up for you after the call. And the symptom screen should be that list. Mm-hmm. I think what I'm hearing from school, kids that are doing camps this summer, that it's a little bit of a cadence now. Like, do you have these 5 things? Some folks are finding that they can't ask every single symptom, but they're saying, do you not feel well? And in particular, do you have a few of them, which is a little bit of an interpretation of the guidance, but I also get that you can't always run the list every day with every person. I will tell you that your school colleagues, and many of you maybe are school, I'm feeling a little bit of pre-K here, which is awesome. School colleagues, we just decided it's new in the guidance tomorrow. The symptom screening is going to be done by parents. The temperature screening is going to be done at the school building. And the symptom screening is going to be, school districts are going to develop like a sign-off, which parents will say, yeah, he doesn't have any of these, and here's the paper. And, again, that's a school district decision. That was a very interesting, long journey of where do you do the symptom screen, where do you do the temp screen. Every state's doing it differently. The CDC said, don't worry about doing them at school. Our team really wants them, at least somehow. There's this word attestation. Somebody's got to sign off that this person, both the staff and the student, doesn't have symptoms. So stay tuned. I think it's going to be messy, but in a reasonable way. I think it does slow parents down a bit to say, okay, right, every day I got to take a peek. This is a big time. This is one of the most important I don't like to pit the strategies against each other, but check in every morning about yourself and your students for these symptoms. So yeah, I can distribute the list. It's on page 4 of the guidance. Mm-hmm. We also need to be asking people if they've been exposed to someone with COVID, which is obvious, but it's just, you got to slow down enough to be like, oh, right, I'm supposed to be quarantining. We're hearing some interesting stories about that. People are wiggling a little.
Breena, there are, even though we did talk about this, there are still questions about facial coverings. So the 3 questions are, do kids 0 to 5 have to wear facial coverings? What about if a town has a mandate? How does that come into play? We did talk, I answered the question about Governor Scott's mandate pointed to the Department of Health guidance, but I don't know if you have any feedback on those two questions.
Yeah, so much to say here. So, the language matters because I get calls on both sides of this. So we need to start every day trying to get all kids to wear masks on over 2. And we need to do that because it works, not for any other reason. There's so little in our control right now with this pandemic. Masks work. So you give it a try, and then you guys are child development specialists. You know this is never going to work. This guy has too much going on in this arena, or it's becoming too much pulling, touching, chewing, eating. I got to let it be today. I might try again tomorrow, or maybe this kid is just not going to do it and the rest of us are. So it's strongly recommended. That's all I can tell you. The pre-K, the 3 and 4-year-olds that are in school buildings, it's the same because the school requires it, but the sentence says special consideration for pre-K. But we want to try. And the other situation I find awkward is if a 6-year-old wears one all day required in a school and then enters into a care after school where people say you don't have to because you're not in the school building or you're not under the school rules, you're under the child care rules. That's confusing to the kid, right? So I guess I just want us all to start our day with it being paramount. But if it doesn't work, it doesn't work, which is how child development rolls anyway with a lot of our stuff, right? Other things we try to do with young people. The town ordinance thing got all screwy. But now that the governor's executive order says it's okay to abide by child care guidance, we've stopped. Steve Rebecco and I were supposed to meet with town health officers to make sure the town ordinances line up with child development. And then ultimately we didn't need to because of the governor's acknowledgement that we are the experts in that space, and we named it as do the best you can.
Breena, there's a question about, so we talked about the health screening. There's also a question about a child who has a parent who works in an area that, according to Governor Scott's travel map, would require them to quarantine when they were here, and they travel back and forth each week, and what would be the implications for that child coming to the child care program?
Yeah, so quarantining is one of the hardest parts about this virus in terms of changing guidance, confusing guidance, and some discrepancies in websites for guidance. So my current best analysis of that situation is that it's only the worker who has any kind of quarantine rules, not anyone that lives with that guy or gal. And the worker themselves is probably waived from quarantine because it's a daily commute. That's my interpretation. And I will tell you, because you're rolling with me in Vermont, we have public health guidance on quarantine, but the primary quarantine interpretation is at the Agency of Commerce and Community Development, ACCD. Many of you, maybe you found them because they have the beautiful map of all the counties for regular travel that changes every Friday at 11 o'clock to see if you can go to Cape Cod. And our nurses get a lot of calls from you all, which we really appreciate. And you guys are amazing because you're getting pressure from families saying, I don't think I should have to because X, Y, and Z. And you guys are saying, wait, hold on. It says here, if you go to the Cape, it's still red, or it's, I think, yellow these days. So please use our team for backup for hard stuff with quarantining, but it isn't the whole family. It's just the worker that goes across.
Breena, there's a question about outside visitors and who can come in and what, particularly around as new families are thinking of enrolling for fall, are they allowed to come into the center to see it, to meet a teacher? Yeah,
so two things there are really important. So first of all, I think someone from Child Development Division's on. We try to do that, and that's my child development colleagues that helped us way back in March understand you never set something up where parents can't enter. That's terrible. So, but also you as the providers need some safety in that decision. So it's health screening, mask, and, obviously allowing parents to see the space, to see what you do. But then after that, it is very reasonable to say, now we're really, if you're comfortable with your visit, now we're restricting visitors for public health reasons. So it's a yes and answer. But here's another nuance. So yesterday on the Vermont After School call, I got into a space. So there are a lot of people that enrich and enhance our kids' lives that come into childcare summer programs and schools. And early on, we had this hard line, no visitors, no volunteers. And then in the last few weeks, we've been asked about learners, which is a good term, meaning college students learning child development from you all. Those of you in Chittenden County, what about the medical students that are learning child development and childcare? So we put into the guidance that learners can come in with health screening and masks. But yesterday I got asked about enrichment, and it was verbal, I hadn't thought it through, and I said, yeah, I think people that are starting to come in and do work with young people around music, baking, cooking, as long as we know who's with whom, attendance, health screening, mass, it's okay. But then Child Development today very appropriately said, Child Development Division, if that's true, we got to get it universally out to you all. So it's not there yet. I'm just dialing that back a sec from yesterday to say, I want that for the kids. I'm sure you do too, but it has to be uniform, well thought out. And I'd honestly love some feedback about it, because this happens a lot with guidance. If you start wanting something for kids, and then you have to ask yourself about the public health principles around it. So I'm just acknowledging with you that space. Parents are different. Parents are obviously need to see the space their kid is learning, especially new. So I'm sorry things aren't straightforward. Yeah.
There's a great suggestion in the Q&A about making a Zoom video of the classroom space and meeting the teachers that families can watch as an option. There's also a question related to that, is if a family was going to come for a tour after hours, should they do a temp check?
Yes.
Okay.
Yeah. It's just what I like about temp checks, besides just that not everyone knows when they have a fever. I like it because it slows us down to say, wait, we just want to check in for a sec. Like, are you feeling well? You just don't want to get that one wrong. So yeah, unfortunately, it's true. We're going to be doing temp checks for a lot of our activities in our world for a while, I think.
Breena, is there a place where somebody could find out what are the best no-touch thermometers that they might want to consider? Is there a place on
that? Yeah, I feel like, and this needs to be revisited, but our public health nurses have kept all that. I think you need to email me and I'll get it to you. Okay. They had a nice little compendium, because we also wanted to make sure there was a supply chain. Because early on we were recommending a bunch of brands and they didn't exist. They were out of stock. So yes, please email through Sherry and I'll get you the right information.
Great. There's a question about transportation, and is there clear guidance? And I don't remember this, so it might be in the guidance. Like if a van is used in the morning for a particular group of children, is there cleaning guidance that if it's going to be used for a different group of children?
Yes. Yeah. So Jill Pearl at CIS wrote, there's a section of transportation that references in the child care guidance, and then there's a separate document at the end that talks about the specifics that relate to sort of state-sponsored van transport of young children. But the general guidance is, yes, it's very safe to do that. And then in between groups, you clean. Just a nice wipe down of surfaces. It's not a deep cleaning, but it's a surface cleaning.
So there was a question about accessibility to testing, and just to ask how you feel that is. Someone had said they wanted a test on the 20th. They're asymptomatic, but we're wanting a test on the 20th because they work in healthcare and they couldn't get one until August 6th. And just how available are tests really, I guess, is what they're looking for you to comment on.
Yeah. So this is a whole webinar unto itself, but I'm gonna try to get 3 or 4 principles out in this ever-changing world. So if you have symptoms, there's tons of test capacity, and you do that through your medical provider. And I've learned a lot about your field since March, and I know some of you don't have docs. I also know some of you don't have health insurance, and I'm really, really wanting you to reach out to me about that, because if ever you need access, we're going to try. And there's groups of people with our Health Connect and our Vermont systems that are trying to get health insurance for people. So that being said, if you have symptoms, we feel very good about our test capacity. We feel very good about access. If you don't have symptoms, we have a bottleneck right now for 4 reasons. I said 3, but it's actually 4. And the state, we are working so hard on these bottlenecks. The first is college kids are they have to get tested either to leave Vermont to go to their college out of state. Vermont colleges have been very responsible at finding their own testing capacity for returning students, but if you're a Vermonter going out of state, you got to get a test. Bottleneck. The second reason we're experiencing bottleneck is because quarantine has this clause, you can get out of quarantine if you get a test, day 7, right? You've read that? Mm-hmm. So there's so many people trying to get out of quarantine that they're filling up our pop-up sites, they're filling up our hospital-associated test sites. The third bottleneck, maybe you've experienced, is pre-procedural testing. So everyone that goes to even just have like earwax removed, I'm being hyperbolic, but all the procedures that were put on hold all those months that need to get done, mammograms, colonoscopies, just routine surgeries, hip replacements, all of those people have to get tested. And then the fourth is we're trying to keep capacity for the folks that are feeling that they just want to know their status, I guess we call that worried well. I hope that term isn't insulting. It just means you feel great, but you have some reason to want to test. So just to be transparent, we're trying to get college kids tested in a different way. We're trying to figure out pre-procedure, and I'm so proud of the health department. We're actually advocating, like, that's a low percentage, like very few of those people have COVID, so that might not be the best. And we're trying to figure out what to do with these quarantine people so that we have enough capacity for people that are working with kids. Mm-hmm. And so I think that's the best I can say right now, but I do want to reassure you that we're well aware. It was better a few months ago, and it got bad in August, and it got bad for those reasons. College kids, and worried well, because we're all sort of thinking, well, how do we kind of feel like we're clean when we start teaching or returning kids to school? So that reminds me to tell you all that the new guidance for schools is, it's going to recommend, think about your movement and behavior 2 weeks prior to entering a school building, if you're a teacher or preschool, because there were some people wanted a required quarantine of all students and teachers, so we had the best start. But we all recognize that's not realistic. People travel, people need to have their lives in the last few weeks of August. But it is a good reminder that adults' health behavior in COVID is what's going to bring the virus into a building. It's not kids. And I'm standing by my science here, and so I don't want us to be surprised when an adult goes to some party, gets COVID, enters a building, and then we have an outbreak and people say, well, gosh, schools aren't safe. That's not right. Schools are safe if they're set up properly and people abide by public health guidance. So I'll stop there. But the testing is, I'd like to come on and talk to you more about testing in a few weeks, because there's also a national supply problem. And I'm not going to go political on a webinar, but Vermont has done a really nice job keeping an adequate test supply, but they know they need more. And we have a lot of really good people thinking about it.
So Breena, we're almost out of time, but 3 quick things. One is people wanted my email address, and that is just Sherry, SHERRY @letsgrowkids.org. So that's that. There's questions about, can we use this cleaner? Can we use that cleaner? I would recommend that they call the childcare licensor of the day for that at CDD. Elaine Crawford did raise her hand on here. She is on listening to that, but I think that's the best place. Best place to get those specific questions about what cleaners are allowed or not. So that's what I'm going to suggest. And then I didn't remember if you answered a question about air purifiers. I heard you talking about fans, and you may have included that. I might have been
those types of, anything that sort of circulates air that's stagnant, you know, which is what I think you mean by an air purifier, do not do. And I really know it's confusing if you don't have 2 windows. And I also know that the one thing I know from our environmental health folks, because we've answered it 5 times, is box fan bringing air in, and then as long as there's another fan that you face out, it's thought to be very safe. And if that didn't make sense, let me know and I'll get the official language from environmental health so you know what I'm trying to say, because I'm terrible at explaining science, those types of, I'm not very engineering oriented.
And Breena, there was, and if you just want to make a short comment on this, there was some questions around some concerns about the student population, the college student population coming back, and if you had any insight as to how that's being...
I can give you, I can give you my view of that because I'm proud of it. Every college in Vermont has been meeting since April, every single Tuesday morning at 8 o'clock with Health Commissioner Patsy Kelso, State Epidemiologist, and our Deputy Commissioner, and I've joined probably over half the times. And they have the most rock solid public health plans I've ever seen. And, you know, those of you that know me, I've got college age kids going out of state to college, and I haven't seen nearly the level of planning. So every kid's quarantining, every kid's being tested. The tests are being sent to the Broad Institute at MIT to a cost, you know, because the state's not paying for those. And then they're going to be randomly tested all fall, which actually doesn't have public health principles behind it. We don't recommend random testing like that, but they're doing it to just keep a handle on it, keep a handle on it, keep a handle on it. And then the other thing they're doing that's remarkable is it's a one strike you're out phenomenon. If a kid is found in a dorm where he's not supposed to, because they're really keeping pods intact, and they go home. They're done with the semester, and they're all signing a contract that says, if I have a party, I'm going, and I get caught, I'm going home. If I have my girlfriend from another college visit, I'm caught, I'm going home. It's way different than the normal sort of student life disciplinary processes you're used to. So Sherry asked for a short answer. I gave you a long one.
Yeah, no,
sorry.
Great. I think we got to just about all of them. But if you, again, you will get a survey and you can add questions there. And there was a question about, is the child care guidance being updated? And that is something that happens on a regular sort of basis. You send out some updates, and
you know, this is where Crystal and her great team, they keep a list, we keep a list, and then we hit some sort of critical place of like, oh geez, now it's like 6 things. You know, you hit on some of them already, especially the symptom list. So yeah, bear with us, because it's a space that I like updating the minute I have a new thing, but if we did that, it would be almost daily. So I promise you, if it was some major stuff, it would be sooner, but it'll be a few weeks hence that we put it all back together.
And typically you do that in a different color. It says new, so that you can look through the document. So if you revisit the document, you can see what might have been updated since the last time. So thank you, everyone. Thank you, Breena, for hosting this. And maybe we'll get together again in September to talk about some of the other things that you mentioned that you'd like to talk about at another time.
Okay, thank you for everything you're doing for kids.
Yes.
I'm so grateful.
Thank you, everyone. Bye.